Hello to everyone. My name is Maria Victoria Mateos, and I work as a hematologist and a director of the myeloma unit at the University Hospital of Salamanca in Spain. I would like to discuss with you is in which specific patients we could potentially select a proteasome inhibitor plus immunomodulatory drugs as part of the maintenance therapy. And you know that the current standard of care for maintenance therapy after autologous stem cell transplantation is lenalidomide, single agent as continuous therapy until progressive disease. Today, I would say that this continues being the standard of care, and it's true that in the clinical practice, many physicians are incorporating the proteasome inhibitor, either bortezomib or ixazomib, as part of the maintenance to lenalidomide, specifically in patients with high-risk cytogenetic abnormalities. As 2021 brought us an important information about the results of a phase 3 clinical study conducted by the Spanish Myeloma Group, comparing lenalidomide and dexamethasone with ixazomib, lenalidomide and dexamethasone in newly diagnosed myeloma patients treated with RVD transplant and RVD as consolidation. The treatment was planned for 2 years, and at 2 years, the minimal residual disease was evaluated, and those patients in which the MRD was negative, they stopped maintenance, whilst if the MRD was positive, they continued 3 additional years with lenalidomide and dexamethasone. Overall, we had the opportunity to see how the addition of the proteasome inhibitor ixazomib to lenalidomide and dexamethasone did not result into any significant benefit in terms of neither progression-free survival nor overall survival. But it's important to note that how overall 63% of the patients remain alive and progression-free at 5 years. And this information, I think that it is important. Why the addition of ixazomib did not result into a significant benefit is true that grade 3/4 toxicities were higher in the population receiving ixazomib, lenalidomide, and dexamethasone in comparison with lenalidomide and dexamethasone, especially some gastrointestinal toxicities, as well as thrombocytopenia, but it's true that in principle, this study did not result into a new standard of care for the use of maintenance therapy with ixazomib plus lenalidomide after autologous stem cell transplantation. However, I would like to remark an important information coming from this phase 3 clinical trial, and it's based on the context of what is the optimal duration of maintenance, because in this study, we had the opportunity to see how when patients were in MRD negativity after 2 years of maintenance and they stopped the maintenance therapy, they resulted also into a significant prolongation in the progression-free survival, especially in comparison with those patients in which the MRD was positive and they continued receiving maintenance, in this case with the lenalidomide and dexamethasone. And this can maybe open the door to potentially stop treatment when the minimal residual disease is negative, in this case at 2 years, and this is under investigation in other clinical trials. And today, I don't know, maybe we can continue incorporating the proteasome inhibitor bortezomib to lenalidomide and dexamethasone or to lenalidomide alone as part of the maintenance to patients with a high risk, based on the observations reported by the Hoban study some years ago. But honestly, the Spanish approach did not support the incorporation of ixazomib to lenalidomide as maintenance in any specific subgroup of patients.